So I want to introduce Professor Sean Deoni. So he's a senior program officer at the Bill and Melinda Gates Foundation, and he's really specializing in maternal, newborn and child health. And he also serves as the director of MRI research and the Department of Pediatrics at the Memorial Hospital of Rhode Island. And he's also a guest professor of engineering at Brown University. His research is really focusing on neuroimaging and the development of portable MRI technology to improve global health outcomes. And today, his presentation will focus on application of ultra-low field MRI in low-income countries, including Africa and South Asia.
Well, good morning, everyone, and it's an honor to be here with you all today, although I can't actually physically be with you all in Australia. I'm going to spend the next few moments talking about the work we've been doing on applying and utilizing low-field and ultra-low-field MRI in low and middle-income countries, in particular across sub-Saharan Africa and Southeast Asia. Before we get going, though, just a few notes to let you know that I have no conflicts of interest to report with respect to the contents of this talk. However, I am a senior program officer at the Gates Foundation and therefore have a number of relationships with different industrial and academic partners. Now, throughout this session, we've heard a lot about the how. How do you build low-field systems? How do you install these systems? What kind of image quality? How do you improve that image quality? But I want to take a little bit of a left turn and talk about the why. Why do we want to collect this sort of data? And for myself, that comes back to thinking about my own kiddos. So this is a picture of my young daughter, Neela, and my younger son, Sethan. And looking at this picture, this really represents the first 1,000 days of a child's life. And the first 1,000 days is something that we hear a lot about, the importance of the first 1,000 days, how they last the rest of that child's life. And indeed, they really do set up the trajectories of lifelong health and learning, be that cardiovascular health, obesity, metabolic health, as well as neurodevelopment. It's also the period of greatest mortality for most children across the globe. But all the skills that you develop across this early time period obviously begin to play a role as that child grows up, has the opportunity to go off to school, go through school, make new friends, and then of course venture off into their professional career. Perhaps they become an MRI scientist like their parents and subject their various siblings to various experiments. Of course, they might also have personal lives, in which case they might be fortunate enough to meet a partner, get married, and have their own children, and begin that cycle over and over again. And of course, when this is happening in a high-income setting, for example, the US, Canada, Europe, Australia, these children have immense opportunity. They have all the best possible healthcare in the early childhood. They have all the sorts of educational opportunities, and they have the ability to succeed. But I want to take a second and think about moving from, say, for example, North America and the US, to some of these lower and middle income countries where children don't have a number of those same outcomes, predominantly because children in these areas face, for example, poor maternal health and antenatal care, setting them up to be born with potential issues or have pregnancies with complications. Malnutrition is prevalent, obviously limiting their ability to grow, be strong, and survive. Poor water quality, sanitation, and hygiene as a major contributor to disease, which can also limit lifespan and increase mortality. And of course, in many areas, social inequality is a cultural norm, which can limit the opportunities, particularly for women or other individuals. Now, throughout the last 20 to 30 years, tremendous progress has been made in terms of reducing infant mortality. We think about infant mortality in approximately 2020. You can see that predominantly across sub-Saharan Africa and Southeast Asia, child death rates were in the order of 1 in every 5. So about 20% of children were dying before age 2. Now, as a result of the introduction of vaccines, improved health, improved sanitation, those mortality rates have dropped tremendously when we think about how they've progressed up until about 2020. And we can compare those, if we just sort of look across these two, and get a really good sense. And this really does show the success of vaccines, etc. The unfortunate thing is reducing these mortality levels even further is where things get challenging. Right? We're now getting away from the easy deaths to avoid and get into some of the more complicated deaths due to disease and communicable diseases. And unfortunately, or at least potentially one role for MRI, is that many of the deaths for these children, particularly in that first 1,000-day period, or indeed actually in the first week of life, can be avoided through the use of early diagnostics, for example through MRI, as well as optimized and targeted interventions. The unfortunate piece, however, as we've heard from many of the other speakers, is that access to early diagnostic tools, in particular things like neuroimaging or MRI in general, is relatively sparse in these areas, sort of on the order of 1 to every 10 to 100 million people, relative to, for example, 1 or 40 devices for every million individuals in the US and many of the developed settings. And taking this even further, the systems that are in place in many of these low and middle income settings are broken. They simply don't work. And to give an example of this is a set of devices that we visited. For example, on the left is a 3T system in Ghana, in Accra, and on the right is a system at Queen Mary Hospital in Blantyre, Malawi. Now, unfortunately, the system on the right has not worked for the past 5 years. And there's really little hope of that system ever running again. And the system on the left, as you can see me standing a little bit closer with my belt hanging down, has been quenched, and there's need for service to that system. But unfortunately, the system has been down for about 2 years. So this really highlights the challenge of not only are there not a lot of systems, obviously due to both the cost and the infrastructural needs for MRI in these various countries, but also those systems that are there tend to be pretty perilous in the sense that any sort of service issue can really bring them down, and they can be down for prolonged periods of time. Now, when we think about the challenges that we have in putting systems into these areas, for example, if we had our 3T MRI Cygnus system from GE, so this is a premier system, what are the challenges that we face in really moving these systems across the globe? Well, of course, the system is heavy, weighs about 13 tons, so you can't just put them anywhere, but they need to be put into a specialized system. They are expensive, between $3 and $4 million when it's all kitted out, and all the various head coils and surface coils, etc., are purchased, as well as the cost to actually site it, which could be an extra $1 to $2 million depending on the location. And of course, the ongoing service fees, which can be on the order of $100,000 to $200,000 per year before we even hire anyone to run it. Of course, then it also requires that infrastructure in terms of cryogens, the RF shielding, and the room to put it in to keep everyone else in the hospital safe from it, as well as we say, those trained technologists and radiographers and radiologists to run, maintain, and read those scans. But the biggest challenge that we have in putting these systems throughout many of the areas that we work in is the power requirements. And unfortunately, in many of the areas, there simply isn't enough power, or it's not stable enough to actually supply these systems on a continuous basis. And so this is really the opening for really thinking about low and ultra low field systems. For example, if we were to compare this with the hyperfine swoop, for example, although it's significantly less powerful, being about 50 times less, the magnet being about 50 times less strong, it reduces a number of the other complications, right? It only weighs about 1,400 pounds, and you can easily move it around with its own motor throughout a hospital. It only does the head. It can do, or similar systems can do extremities, but it is really sort of a focal system, which does limit its use. However, the majority of cases in LMIC settings do tend to involve neurological or spinal applications, and so that's not necessarily a huge constraint or disadvantage. The biggest advantage is, of course, being price. These systems are significantly cheaper for purchase as a capital cost. They also require far less infrastructure. Right? We don't need to build additional rooms or take over additional rooms within various hospitals which may not have room to spare. They don't require the large shielded rooms to be able to put them in. You can put them in the corner of a room, for example, and they won't interact with other patients. And it just allows you to put these systems and move them around a lot easier. And perhaps the biggest advantage to many of these systems, particularly those that are based on permanent magnets, is that they don't have that huge power requirement. In fact, they require about the same amount of power to run a coffee maker, and they just can plug into the regular mains, or indeed can be run off alternative energy sources, be it battery or solar, as backup when the main power is unavailable. As I said, over the past 5 or 6 years, we at the Foundation, as part of a larger Unity project headed by King's College London and a partnership with Hyperfine and other industrial partners, have really been working to put these systems across a number of different geographies and locations throughout sub-Saharan Africa and Southeast Asia. And just to give a sense of some of those locations look like, we have both community centers. So for example, on the top left is a community, a rural village in Shivgar, called Shivgar, in very close to Lucknow in Uttar Pradesh, India. So it's sort of the northern part of India near Nepal, about an hour and a half to 2 hour flight from Delhi. A second example community cohort is in Kenya, so that's bottom left. This is in the large Kanabe slum, which is the largest slum in Africa. We also have healthcare settings. So for example, on the top right is a healthcare setting in Bahar Dar, Ethiopia. And below that is a NICU location, so a system actually in a NICU and within a children's hospital in Lusaka, Zambia. Now, as I say, the easy thing about low-field systems is that they can be integrated into any of these environments, again, without requiring huge infrastructural costs or construction. So for example, this is the system that's actually in the Lusaka, Zambia hospital. And again, you can see how it's simply in a room, and it really allows you to get up close, even with electronic devices and whatnot. As I say, we can take this to the next step. These systems can also be run without mains electricity supply, so they can be run on backup generators, batteries, etc. And to exemplify that, this is a system that was installed in Zimbabwe, in which the team at KCL, in association with the team in Zimbabwe, installed solar panels and actually made this into one of the first solar-powered MRI facilities, indeed neuroimaging and neuroscience facilities, because there's also EEG systems in this center, all running off solar power, so completely able to continue on without drawing power from the mains. These are a few examples, but to give a sense of the scope of the areas that we've been putting systems in, they're shown here in these various blue dots, and where you see a number means that we have 3 systems within pretty close proximity. But up until now, we have about 50 scanners installed across about, 27 different locations in about 14 different countries. One of the things that we want to make sure as we're putting these systems in is really coming back to making sure that all these systems are performing similarly. And so this is work that we've done, for example, really trying to harmonize measures across these different sites. And we do that using phantoms that have been custom made to fit into the Hyperfine head coil. These are systems made by Caliber MRI in Colorado. And they comprise 3 different sets of mimics, a T1 array, a T2 array, as well as an ADC or diffusion array that really allow us to look at the signal characteristics across different T1s and T2s that are representative of tissue, as well as diffusion coefficients that are representative of tissue, particularly in the neonate infant, and early childhood periods. There also contains geometric markers and whatnot, so we can look at distortion. We can see, for example, across the different sites how these systems are behaving in a very consistent manner, telling us again when we look at even, for example, T1 and T2 values, that these systems are behaving very similarly despite the obvious differences in setting and therefore the climate control that they may have or not have. In many cases, these systems are running at 25, 26, 27 degrees Celsius, much beyond really the operating window or ideal operating window for the system, and yet remain relatively continuous and constant. We can also look at how these systems change over time periods, again using this phantom to really allow us to understand the system performance and really understand, as we do longitudinal studies or longitudinal follow-up of individuals, whether those differences that we're seeing might be related to changes in the system or indeed changes with respect to pathology or tissue development, etc. One of the things that we've been working on using these systems really has been to first begin to understand neurodiversity. Are children developing similarly across all of these sites? Given the wide differences in environmental exposures and influences across these different sites, differences in malnutrition, differences in overall childhood adversity, disease, etc. rates, we would expect there to be quite a significant difference in overall development. And indeed, as an example, just taking a few of our sites, we can see that there is pretty significant differences in development, even when controlling for head size and normalizing for overall child size, which is an important characteristic to do here, given that these children are often stunted and or wasted, that meaning that they are not at the same height as we would expect children to be, or they're at much lower weight than we would expect them to be. And so we need to correct for that, because obviously the brain grows to relative to the skull size, which is related to overall physical size. So when we correct for that, we see that there is indeed a significant deviation across different populations, moving, for example, from South Africa at the top, which is more of a middle income country and setting, and might be more representative, for example, what we might see in Europe, Canada, Australia, the US, and then moving down, for example, into Malawi, Uganda, Pakistan, and then down into Ghana. So really showing that their environmental influences are shaping how these children are developing. And we can delve into this a little bit more. If, for example, if we were to look at one of our populations, so coming back to our population that we had in India, this is a rural village in northern India called Shivgar. As I say, it's about a 2-hour drive or 50 kilometers away from Lucknow. And it is an area of immense malnutrition and adversity. It has some of the worst childhood outcome metrics and health metrics across the globe. When we think about the number of children who are stunted or wasted across the globe, that's an estimate of about 250 million children under age 5 are either stunted or wasted or not achieving their full developmental potential. And about 50 million of those children, or 1/5, are in this area of Uttar Pradesh. It is also an area that is very conservative, so they still follow a number of social norms around caste and around social inequality and gender roles. So we were able to do many of the same assessments that we might think about doing in a high-income setting, in a high-income lab, and then we can begin to understand and really look at how brain development differs across these sites and these locations. And just to give a sense of this, again, on a very high level, this is looking again at just white matter growth in our, for example, in a high-income cohort based in Providence, Rhode Island, relative to the same brain development, white matter development in those children growing up in Shivgar. And you can see a couple different things here. One, you can see the differential between male and female development, but you can also see by looking at the scale, the Y scale, that these kids are shifted down. And again, a lot of this can be being driven by simple stunting and wasting, right? These children are just not growing as we would expect. So we need to account for that, and when we do, we see the expected results that most of the male-female differences in the US go away. They're accounted for simply by overall child size, but they don't go away in our children in India, and in particular in this area. Moreover, again, going back to the use of the phantom, we know that these values should be about the same, and yet we see, for example, that even the largest boy at about age 2.5, almost 3, is about the size of an average boy or girl at around 18 to 19 months in the US. So again, really kind of demonstrating this differential in development. And that's not to say that one is bad, one is good, but certainly that these children are developing differently in response to their environments. And we can look at this a little bit more specifically. We can look across different brain regions. We can look at subcortical volumes, for example, but we see the same sort of story, where again, even controlling for overall child size, there's a significant differential in development between boys and girls. Not only is this true actually when we look at structural development, but we also see it being true when we look at functional brain development. And so this is again looking at children and looking at functional connectivity data in children, boys and girls growing up in the US, where we see pretty much the same between boys and girls in terms of increasing connectivity over the first 3 years of life, as well as decreasing connectivity. When we look at the boys in India, we see very similar patterns in terms of increasing connectivity to what we see in Rhode Island, but the girls just being very, very different. And of course, some of this could be being driven by some of the social and gender inequalities that we know are prevalent in this area. So, for example, there's an accepted norm of treatment towards girls and young women in this area, and obviously very significant expectations in terms of the years of education, healthcare seeking, nutrition, etc. In many cases, girls eat after the boys in order of priority. And so when we take all of that sort of information that we acquire on these children, we can go back and we can understand, for example, that the major predictors of neurodevelopment in this cohort is whether you're born a girl, early weight gain, particularly over the first 2 to 3 years of life, and then factors like maternal education. When we were to do the similar analysis in the US, Europe, etc., what we would find is that maternal education would definitely be number one as a primary predictor. Boys and girls, really your gender or biological sex would not factor in, and weight gain might play a role if these children were low birth weight or premature, but otherwise not a significant impact, particularly over the first 2 years of life. And so what this is really telling us is that these children actually are set up in a way with a generational cycle for potential ongoing impacts, right? So you're born a girl, for example, that obviously leads to that child being given fewer resources in terms of nutrition. They eat last, healthcare being lower, schooling, as we saw, being lowered, and even care and interaction being sort of much lower than what we'd see for boys at the same age. And this, of course, then might mean that those young girls grow up to be young women with reduced maternal education, reduced maternal autonomy, and then this feeds back into that overall cycle. So these are the sorts of information that you can abstract and quantify using these low field systems in some of these areas, and really start to understand the impact not only of aspects such as nutrition, interaction, etc. on development, but how those environmental conditions really shape child development. So this is even outside of, for example, the use of MRI as a diagnostic tool in healthcare. But there's a few challenges that we've run into that I want to highlight. A lot of the work that we've heard about over the last few talks, and certainly we'll hear over the next few talks coming up, as well as throughout this meeting, is the idea that if we can just get the cost down for low field systems, we can solve all the access problems. And I want to suggest that that's not actually the challenge, right? The challenge is not necessarily cost. It's everything else that goes around in terms of the ecosystem for that system. MRI systems for use in various LMIC health centers really do have unique challenges that they have to meet beyond cost. There's limited space in many of these hospitals. All space is being used by patient-facing activities. We have very unreliable and unstable electricity. So bringing that down and making these things able to be run on backup generators or alternative energy sources. There's limited computational resources, limited electronic medical records, very little intra and extra-institutional connectivity, very few trained personnel, radiologists, radiographers, and technicians, and they're often very remote settings, right? So getting to them for maintenance is very challenging. And so when we think about this, really thinking about as we're designing these systems in terms of this the sustainable MRI ecosystem, that's not just the hardware and software of the scanner, but thinking about maintenance, about infrastructure, about personnel, and then ultimately how you're storing and analyzing that data. And to give a sense of that, even with the systems that we've had, for example, when they've run into some challenges, trying to find the parts, for example, this system in Malawi, trying to find just some Allen keys to get access to the system to make a slight service to it was quite challenging, right? We ended up having to go to several hardware stores, ended up taking about 4 or 5 hours to go and find a pretty simple set of tools. And as a result of this, as I say, many of these systems are broken. About an estimated 40 to 90% of imaging equipment in these various settings is unused, right? Leading to these equipment graveyards where systems just sit there and are unused, which is tragic. Even more tragic is that many of these systems sit in the hospital, taking up hospital space that could be being used for patient care. Of course, we also have challenges with personnel. When we think about, obviously there's a very big disconnect between the number of MRI systems as well as CT systems and ultrasound systems across different areas. Well, the same is true in terms of personnel. We think of radiographers and radiologists across these different areas. Many of them are obviously in HIC settings, and it's not surprising. They go to where the systems are that they're going to use. But this creates a challenge when we start building up and bringing in new systems as to who exactly is going to run these. And just to give an example of this, and this is one that I've used before, this is our system that we've installed, for example, in Blantyre, Malawi, or this is in Zomba, Malawi, so a more rural area. But just to give a comparison between, for example, a single hospital, MGH, in Boston. When we think about Malawi servicing approximately 40 times more individuals, and yet they have about 1/7 the number of scanners, about 1/80th the number of radiologists, and about 1/10 the number of technical staff to actually run that system. So when you think about this disparity between these two areas, it's pretty profound. So taking this all together, obviously I think we can all get on board with the idea that every child deserves a chance for a healthy and productive life. And there is a significant role, for example, in the use of diagnostic imaging, in particular MRI, across low and middle income settings to help prevent early mortality and improve overall childhood health. Unfortunately, as we say, access to MRI and other medical imaging modalities is limited in many of these areas. And we think that low and ultra-low field MRI might enable increased access in these various resource-constrained settings, given that they cost less, require less infrastructure, and have lower maintenance costs. Of course, we are beginning to see that these systems are useful not only in terms of just general diagnostics, but in terms of research, in terms of early neurodevelopmental factors that shape development. However, again, the challenges with setting these systems up does not end with an affordable scanner. Innovation is needed to ensure early, easy operability, maintenance, and service to avoid these just becoming part of the ever-growing equipment graveyard in many of these settings. So with that, I'll end with this statement that we see across the foundation, but I think really resonates with the crowd here, that if you want to go fast, go alone. If you want to go far, go together. And I think we all certainly want to go far. We want to see what we can do to these systems. And the best way to do that is to all work together to take our unique individual talents and combine them. So thank you so much. Again, very sorry for not being able to be with you all today. Happy to take any questions in the Q&A, as well as if you reach out to me directly at the Gates Foundation. And thank you so much.
I hope everyone has enjoyed this wonderful talk because, I think it really shows that ultra-low field MRI is really promising and we can hopefully really apply this in low-income countries. But it's also not just like I feel like we have now increased awareness as well for the other challenges as well. It's not just about putting an ultra-low field MRI scanner in these countries, but it's all the factors around it as well. So I really want to open the floor as well. Any afterthoughts? Again, I realize Sean Deoni is not here, but any afterthoughts or comments?
Yeah, it's amazing. I mean, we started working with Sean on these Unity projects, and if you look up the Bill and Melinda Gates Foundation in terms of their grant funding, their whole strategy and priority is to increase or decrease infant mortality, and they've invested a lot of money in the Unity project across Sub-Saharan Africa and Asia in particular, and to be able to see the results of this is just phenomenal. And we know that there's disparities in the provision of healthcare and in these countries, but to be able to see the age differences and the white matter development in countries like India and Africa compared to the Western world is pretty amazing. Are there any comments or questions?
Okay, I will introduce our next speaker.